All right, welcome team to this Anesthesia Learners Academy explainer. Today we're jumping straight into the high-stakes world of maternal cardiac arrest protocols. Imagine stepping onto the wards and suddenly you're facing a code OB. It's rare, but man, it's incredibly critical. You're literally fighting to save two lives at the exact same time. But as medical students and future docs, you've kind of got to completely rewire how you approach a standard resuscitation.
So here's the absolute golden rule. The best way to save the fetus is to successfully resuscitate the mother. This is our foundational mother-first philosophy, right? It literally dictates every single thing you do, every medication you push, and every surgical intervention during a maternal cardiac arrest. Because if you don't focus your primary efforts on getting the mother's circulation back, well, both patients will be lost.
Okay, let's take a quick look at our lesson plan for today. We're tracking the chronological flow of a real-world emergency response. We've got 1. The physiological barrier. 2. Modifying standard CPR. 3. Diagnosing causes with the BOCHCOF acronym. 4. The 4-minute rule. And 5. Prioritizing maternal survival. Let's get right into it.
Starting off with Section 1, the physiological barrier.
So, right around the 20-week mark, a pregnant patient's body undergoes these massive anatomical changes that, quite frankly, directly sabotage our life-saving measures. The medical term for this barrier? Aortocaval compression. Basically, when a pregnant patient lies perfectly flat on her back, her heavy, enlarged womb, the gravid uterus, physically squashes her major blood vessels. It compresses the inferior vena cava, severely limiting blood returning to her heart, and it pinches the aorta, blocking blood trying to pump out. This compression alone can instantly drop a mother's cardiac output by up to 40%. 40%! That is huge!
This actually brilliantly illustrates the mechanical problem we're facing. Think of it like the boulder on the hose analogy. Imagine trying to water a garden, but there's a heavy boulder sitting directly on the middle of your hose. In this scenario, doing standard chest compressions is just like desperately pumping the faucet. I mean, no matter how hard or fast you pump that faucet, the water, or in this case, the blood, simply cannot reach the brain and heart because that squash section is entirely blocking the flow.
And because of that physiological boulder, we've got to completely change our game plan. That brings us to Section 2, modifying standard CPL.
You simply cannot run a standard code on an obstetric patient. If you look at standard ACLS versus obstetrician ACLS, you'll quickly notice that normal positioning and standard IV protocols will actually work against you here. Like in a normal arrest, you lay the patient flat, push drugs through whatever line you have, right? But in an OB collapse, doing that means your chest compressions are failing and all your life-saving drugs are just pooling in the lower body, completely trapped beneath that compressed vascular system.
So we need some mandatory modifications. Step 1, you need a dedicated team member performing manual left uterine displacement, or LUD. They have to stand there and literally push the uterus up, off, and over to the left side. You've got to get that boulder off the hose. Step 2, keep the patient flat on a firm surface. We actually used to tilt the whole patient on a wedge, but honestly, that ruins your leverage for high-quality chest compressions. Just keep her flat and only move the uterus. And step 3, make sure you place your IV access above the diaphragm, like in the arms or neck, so your medications bypass those blocked lower vessels and actually make it to the heart.
Now, while your team is hammering away at that modified CPR, the clinical leads need to jump into Section 3, diagnosing causes using the BUCOG-EPS mnemonic. What's really fascinating here is how we adapt our standard diagnostic thinking. We're still looking for the usual suspects, of course, but we use the BUCH-OPAS mnemonic to rapidly scan for specific obstetric culprits. So that's B for bleeding, E for embolism, A for anesthesia complications, U for uterine acne, C for cardiac disease, H for hypertension, like preeclampsia, O for other standard causes, P for placental issues, and S for sepsis. Let's actually zero in on a couple of the trickiest ones on this list.
All right, for the letter A, anesthesia complications. We have to watch out for something called the basal-gyrus reflex. This usually pops up after a spinal block. Think of it like a computer's malfunctioning safety switch. Normally, if your blood pressure drops, your body's sensors tell your heart to speed up to compensate, right? Well, in this rare reflex, those sensors just panic. They mistakenly send a signal to shut the heart down entirely, leading to sudden asystole.
Then we have the letter U for uterine atony, which is a massive leading cause of postpartum hemorrhage.
Look, after a baby is delivered, the uterus is supposed to contract super intensely to squeeze the bleeding vessels shut. With atony, think of the uterus like a giant, floppy sponge. Instead of wringing itself out tightly, the sponge stays big and soft, failing to clamp down. Blood just keeps pouring out. And because young, healthy patients can compensate for blood loss for a really long time, their blood pressure might only drop right before a catastrophic collapse. So, depending on which BO-CHOPS trigger you identify, your team must be ready to deploy specific antidotes instantly. If a patient arrests while on magnesium for preeclampsia, bam, you need calcium chloride or gluconate. If they have local anesthetic systemic toxicity, you push intralipid 20%. And if you're dealing with massive hemorrhage from that floppy sponge we just talked about, you rapidly administer tranexamic acid, or TXA.
And this brings us to the absolute climax of our protocol, Section 4, the 4-minute rule and emergency PMCS.
So what happens if you're pushing these drugs, you're doing perfect modified CPR, and the mother's heart simply will not restart? I want you to really think about this question. Why do we perform a bedside emergency cesarean section at exactly the 4-minute mark? You know, most people, even some early clinical students, mistakenly believe this super aggressive timeline is solely designed to save the baby before the oxygen runs out. But actually, that is secondary.
The timeline here is incredibly strict. From minute 0 to 4, you provide high-quality modified CPR and LUD. But if the mother's heart hasn't restarted at minute 4, a perimortem caesarean section, formerly known as a resuscitative hysterectomy, must begin immediately at the bedside. You do not wait. You don't move her to the operating room. You perform it right there, with the ultimate goal of delivering that baby by the 5-minute mark.
The reason we do this goes right back to our mechanical physiology, perfectly captured by the sinking ship analogy. Think of a sinking ship carrying a massive waterlogged weight. To save the ship, you can't just keep bailing water. You have to jettison the weight immediately. Delivering the baby unloads the maternal circulatory system, removes that intense compression on the vena cava and aorta, and keeps the mother, the ship, afloat so her own engine can finally be restarted.
Which smoothly brings us to Section 5, prioritizing maternal survival. This really reinforces why we take such drastic, immediate surgical measures right in the middle of a code.
Remember that number we talked about earlier? 40? By surgically emptying the uterus, we instantly and completely abolish aortocaval compression. That single action can immediately restore up to 40% of the mother's cardiac output. Suddenly, those chest compressions that weren't doing much before, they become incredibly effective because the pathway is finally clear.
As the clinical documentation states, emptying the uterus unloads the mother's circulation, giving her own heart the best chance to start beating again. The exact moment the baby is delivered, a dedicated neonatal resuscitation team will immediately take over care of the infant. They'll have all their warming equipment and respiratory gear ready to go. But for you, the primary arrest team, your objective remains crystal clear. Saving the mother is the ultimate goal, because saving her is exactly what made saving the baby possible in the first place.
Excellent work today, team. These concepts, aortical caval compression, modified CPR, BO-CHOPS, and that critical 4-minute rule, these are the foundations of saving 2 lives in literally the absolute highest stakes scenario you can face. To keep mastering these clinical protocols and building up your emergency medicine foundations, please remember to like, subscribe, and share this explainer from the Anesthesia Learners Academy. Your support is what helps us keep bringing the classroom right to your screen.
But before we go, I want to leave you with this final thought to really test your real-world readiness on the wards. If the alarm rang for a code OB tomorrow and you sprinted into that room, would your team know exactly who was on Balder duty? Because knowing the science is one thing, but establishing those roles the very second you step into the room, that is what actually saves a life. Think about it, and I'll see you in the next explainer.